Here we go, guys. Last lecture for the day. I'm so excited. We're talking about peptic ulcer disease, one of my favorite things to talk about. And I'm getting closer, one step closer to little Liam making his presence among us. So here we go. Peptic ulcer disease is what we're talking about, and our learning outcomes are the same. Pathophysiology, etiology, risk factors, clinical manifestations, tests that we use, and care for patients across the lifespan. So, overview of peptic ulcer disease. It's caused by a break in the mucus lining of the GI tract. It develops when the mucosal barrier is unable to protect the mucosa from the damage by hydrochloric acid and pepsin and the gastric digestive juices. It can happen anywhere in the GI tract, so even though we call it peptic ulcer disease, it could be a duodenal ulcer, it could be a gastric ulcer. All of those are peptic ulcer disease and caused by this gastric juice. Duodenal ulcers are the most common, and they happen about age 30 to 55 and more in men than women. And gastric ulcers, which also occur, they happen in the stomach, and they're more common in older adults. And all ulcers are common in smokers and NSAID users, so no smoking. Pathophysiology and etiology, thought I'd give you a good picture of that. So you can see here's the normal stomach, and then here's your gastric juices kind of happening all over the place here. And let's see, oh, I'm sorry, let's go over here. And you can see where here's a little ulcer right here, and it's the excess secretions that start leaking in, and that's what causes the ulcer. We have a YouTube video to watch, so let's see. I'll post that video so that you can watch that. And then it's a really good video from this nurse. I can't remember his name, but he does a really good job explaining peptic ulcer disease. So I'll post that as well for you to watch. The mucosal barrier is a thin coat of mucus gel and bicarbonate, and that protects the gastric mucosa. And when it can't protect that gastric mucosa, the digestive juices form an ulcer. The other reason that we get ulcers is from H. pylori infection. That happens in about 70% of individuals with peptic ulcer disease. It's spread by oral to oral contact or fecal oral spread, and it contributes to ulcer formation, and especially gastric and duodenal ulcers. So what happens is the innermost layer of the stomach, the gastric mucosa, has these columnar epithelial cells supported by a middle layer of blood vessels, glands, and a thin outer layer of smooth muscle. And the H. pylori infection colonizes in the stomach, and the bacteria produces enzymes that reduce the efficacy of the mucosa, so it doesn't work as well to protect the stomach. And that inflammatory response to H. pylori contributes to the cell damage. So that's what happens in H. pylori. Really important to know that H. pylori is one of the major reasons for peptic ulcer disease. Non-steroidal anti-inflammatory drugs also contribute to peptic ulcer disease. Systemic and topical mechanisms interrupt prostaglandin synthesis by disrupting the action of enzyme of the COX enzyme. So there's COX-1 and COX-2, but the COX-1 maintains the integrity of the gastric mucosa, keeps it intact, and the COX-2 is the thing that responds to inflammatory stimulation. So topical injury happens when the NSAIDs cross the lipid membranes of gastric epithelial cells, damaging the cells themselves. Peptic ulcer disease may also affect the esophagus, the stomach, or the duodenum. And they can be superficial or they can be deep. They're usually in the proximal portion of the duodenum near the pylorus, and they're sharply demarcated and generally less than a centimeter in diameter. So let's talk about pathophysiology and etiology. Here we go, another good picture. Here's a little ulcer right up here. Here's another ulcer here, and an ulcer down here in the duodenum. So you can see how it kind of goes through the different layers. The gastric ulcers are found on the lesser curvature area and immediately proximal to the pylorus, and you see a lot higher incidence of stomach cancer with those. And peptic ulcer disease may be chronic and have some remissions and exacerbations that are associated with trauma, infection, or some other stressors. It's a chronic health problem caused by a break in the mucosa line of the GI tract where it comes in contact with that gastric juice. So let's talk about H. pylori. It often occurs in several members of the family, obviously because you're drinking the same water. This can come from bad water, and also because of that oral to oral route or oral to fecal route. So just whenever the water supply is contaminated, it happens. I've had H. pylori, but I've been to 24, well, I've been to more than that, but I think 30 countries, but 24 with my husband. Anyway, I got it obviously from bad water, so you have to be careful about the water that you drink. And this is what the H. pylori looks like. So H stands for Helicobacter pylori, and here's what it looks like. This is the little shape of it. But it's not really, doesn't have anything to do really with your diet except for maybe bad water. And then caffeine and alcohol consumption can exacerbate it. So we want to stay away from caffeine and alcohol and cigarette smoking. So some risk factors for H. pylori. For peptic ulcer disease, 1 in 6 people who have H. pylori develops an ulcer, so it's really important to take care of that H. pylori. Chronic use of NSAIDs, especially aspirin, that would be the worst. Cigarette smoking doubles your risk of getting an ulcer. It inhibits the secretion of bicarbonate by the pancreas, and it may cause a rapid transmission of gastric acid into the duodenum. Advanced age can also be a risk factor. Low socioeconomic status, crowded or unsanitary living conditions, which I've been in many times in different countries. Family history of ulcer can increase your risk, and other drugs like steroids and bisphosphonates can also do that. So how do we prevent it? Well, I've talked about this many times before, but wash your hands. Meticulous hand hygiene. Also making sure that food preparation is done well. Medication to reduce the occurrence of peptic ulcers for patients who are using NSAIDs. So if you're already using NSAIDs on a regular basis and there's no way to get away from that, that's the best treatment. Then we might want to add a histamine receptor agonist, a PPI, or Cytotec to help protect, or even change to a COX-2 NSAID, which would be less of a problem with developing ulcer disease. So all patients started on long-term therapy with NSAIDs should be tested on a regular basis for H. pylori for those very reasons. Just a huge incidence of that happening. So some manifestations. Here's another picture. Abdominal pain is the classic sign. It's sort of a gnawing, burning, aching kind of pain. Hunger-like. You feel hungry. It's usually in the epigastric region, but sometimes it radiates to the back. Usually gets better when you eat, and it can also be accompanied by, let me put myself out here, heartburn, regurgitation, vomiting, and in an older adult, you may not see those same symptoms. The presentation might be a little bit less clear. They might have a GI bleed or perforation or even chest pain or dysphagia. Another coloring picture for you that we'll give to you. But this is a nice little picture of the clinical manifestations of peptic ulcer disease. So the different types of ulcers, you can have the gastric ulcers, you can have duodenal ulcers or stress ulcers, and then there's different symptoms depending on which one, but the risk factors can be stress, H. pylori, alcohol, and smoking. Complications can be hemorrhage, so that can be a result of ulceration, erosion into blood vessels of gastric mucosa. You can have a gastric outlet obstruction that may result from edema surrounding the ulcer, smooth muscle spasm, or scar tissue. Perforation is probably one of the most serious complications, and that's penetration of the ulcer through the mucosal wall. So we need to know signs and symptoms of perforation, especially the rigid board-like abdomen. That's an emergency. That's the most lethal complication that you can have is a perforation, so we need to look out for that. Chemical peritonitis is another possibility, or bacterial peritonitis within 6 to 12 hours. That can happen as a result of the perforation, and so it's really important to treat that quickly. They can have immediate severe upper abdominal pain radiating throughout the abdomen, maybe even to the shoulder when that happens. Some other clinical manifestations, we have Zollinger-Ellison syndrome is a form of peptic ulcer disease that's caused by a gastrinoma. Sorry, I'll get myself out of here. It's a tumor that secretes gastrin, and 50 to 70% of them are malignant. And it's the same kind of ulcer-like pain that we already talked about is common, and it's due to high levels of hydrochloric acid, which impair the fat digestion and absorption. So you can have diarrhea and steatorrhea. And steatorrhea is basically excess fat in the feces. You can also have, with Zollinger-Ellison syndrome, the complications can be bleeding and perforation. So we're going to look for those signs and symptoms of those as well. So collaboration, we're going to focus on treating the cause. So we want to eradicate H. pylori. That's the #1 way to treat peptic ulcer disease, is to eradicate H. pylori. And eradicate just means absolutely destroy it, right? And then treat or prevent any ulcers related to the NSAID use. So some diagnostic tests that we do. Let me get myself out of here again. Upper GI series can detect 80 to 90%, and it's less costly than doing a gastroscopy. An upper GI series is a radiographic X-ray examination of the upper GI tract, and the esophagus, stomach, and duodenum, which is the first part of the small intestine, are made visible on the X-ray because of a liquid suspension, and that's usually like barium, so that's where we talk about a barium GI, or a water-soluble contrast. However, a gastroscopy, and so this is what you would see on an upper GI, this is what an ulcer looks like. A gastroscopy is a procedure where this thin, flexible tube called an endoscope is used to look inside the esophagus, the stomach, the first part of the small intestine, the duodenum, and it's also sometimes referred to as an upper GI endoscopy or endoscopy. And that endoscope has a light and a camera, just like any of these scopes that we use for anything. It's all very similar with the light and the camera on the end. They can take pictures as they go through. If they're in there doing the gastroscopy, they can also do biopsies and visualize the esophagus, gastric, and duodenal mucosa. If they do a biopsy, they're going to check it for H. pylori. They can check for H. pylori in many different ways. They can do a rapid urese test. They can do it microscopically. They can do a culture. Those are all, they would do that from a biopsy. But you can also do non-invasive testing for H. pylori. You can check the blood, and that can be positive for H. pylori. You can do fecal testing, where they do a stool specimen, or you can even do a breath test. Gastric analysis if the Zollinger-Ellison syndrome is suspected, and they'll look at the gastric acid and do an analysis of that. Surgery. Well, if they figure out that it's from H. pylori, they're probably not going to do surgery. They're just going to want to eradicate that H. pylori. Older adults who had a gastric resection in the past may have some complications, so you might see it in that case, but typically you're not going to see surgery for peptic ulcer disease. There is pharmacological therapy. We want to use combination therapy to eradicate H. pylori, so we want to destroy it and get rid of it. So there's a couple different ways that we'll do it. 2 antibiotics with a proton pump inhibitor, or PPI, is called triple therapy. And the antibiotics we would typically use with that are clarithromycin, amoxicillin, and then we'll do metronidazole. And we'll do that for 10 to 14 days. We also may do a proton pump inhibitor with bismuth and 2 antibiotics, which is called quadruple therapy, and we'll do that for 10 to 14 days. And we do that quadruple therapy, we'll typically use metronidazole and tetracycline would be the antibiotics that we would use. If it's an NSAID-induced ulcer, then we're going to just discontinue that NSAID, and if that's not possible, we'll use the PPIs twice a day, morning and night. We might use a histamine receptor antagonist or sucralfate, which is the same as Carafate, but I don't think I typed that in there. We also may use medications that decrease the gastric acid, like the PPIs that bind acid-secreting enzyme that functions as a proton pump. The other one we may use that decreases gastric acid, like we talked about, the H2 receptor antagonists. They inhibit histamine binding to receptors on gastric parietal cells and reduce the acid secretion. Then we also might use mucosal protectors. So Carafate binds to proteins in the ulcer base and forms this protective barrier. We might also use bismuth, which is Pepto-Bismol compounds, and that stimulates mucosal bicarbonate and prostaglandin production to promote ulcer healing, and also has an antibacterial action against H. pylori. So that's why we use that with the therapy to eradicate the H. pylori. Antacids may interfere with the absorption of iron, digoxin, some antibiotics, and other drugs, so we have to be careful of those, but they stimulate gastric mucosal defenses and provide symptom relief quickly. Prostaglandin analogs, such as Cytotec, stimulate mucus and bicarbonate secretions and inhibit acid secretions, promote ulcer healing, and prevent NSAID induce ulcers, but Cytotec has diarrhea as a common side effect and is also contraindicated in pregnant women. And it's used with other medications actually to cause abortions. So it's highly, I think it's called embryogenic. Basically, it really has a very bad effect on the embryo and the baby. So we don't want to use that in pregnant women. Non-pharmacologic therapy. Nutrition is really important. Balanced meals at regular intervals. We used to say that people should avoid spicy foods and all different kinds of foods, but we don't think that a bland diet or restrictive diet is really that helpful anymore. And they say that mild alcohol intake is not harmful. It's people who drink a lot of alcohol that have a real problem. But smoking, we know, is a problem. It slows the rate of healing, increases the frequency of relapses, and of course we know that smoking and drinking will kill you. Okay, moving right along, some complementary health approaches. Let me get myself down here out of the way. Healthy ways of lowering stress would be, since stress is a risk factor with ulcers, yoga is a healthy way to decrease stress, and I thought I'd include a nice little picture. This is my oldest son and his girlfriend doing some yoga moves. Walking, listening to music, or whatever the patient enjoys to help them reduce their stress. Increase in the fiber in their diet, and even 25 to 50 milligrams of zinc a day have been proven to be effective in some cases. With children and adolescents, the incidence of peptic ulcer disease in the pediatric population, bleeding occurs. There's 378 to 3,250 cases per year. I'm not sure that's super important, but anyway, now you know. Here's some cute little children. This is my oldest, Ella, and then my sweet little niece, Kiki, and my sweet little niece, Morgan. They're all only 9 months apart, but you can tell that they're very different in sizes. But anyway, acutely ill children should be assessed for health disparities, and just make sure that they're not at risk for peptic ulcer disease, again, especially if we think about H. pylori. Pregnant women, here we go. Here's my daughter-in-law Krista and my son Luke. Further assessments needed for epigastric discomfort, especially if they start vomiting blood or have weight loss, and endoscopy may provide some further data without damaging mom or baby. And PPIs would be the treatment, and they're safe and effective and appropriate during pregnancy. Older adults, this is my sweet mother-in-law who was recently in the hospital. They do have peptic ulcer disease, usually associated with NSAIDs, so they're gonna give some high-dose H2 receptor antagonists, maybe Axid, Pepcid AC, one of those to help lower their risk of peptic ulcer disease if they're having to take NSAIDs. Okay, we want to identify the symptoms that they're having with peptic ulcer disease, a family history of H. pylori, because we know that it does happen in families. Promote their health by advising them to avoid smoking, avoid NSAID use if possible. Encourage them to seek treatment for any GERD or chronic gastritis, and they're both associated with H. pylori, so we want them to try to make sure that they're not having any of those symptoms. We're going to observe our patient, do an interview, look for epigastric or left upper quadrant pain, heartburn, nausea, vomiting. Ask them, what makes it better? Does it get better when they eat? Does it get worse when they're hungry? If they have any coffee grounds in their vomit or bright blood, then that's a bad sign for ulcer disease. And ask about medications and smoking. Of course, we want to examine the abdomen when we're doing our head-to-toe assessment, check stool or vomit for blood, and nursing diagnosis that you would expect. So what do we want to do? Well, we don't want them to have any complications related to the bleeding, signs and symptoms of infection. We want them to stay with a normal fluid volume balance, including their urine output of 0.5 milliliters per kilogram per hour, dietary intake that meets their needs, risk factors associated with peptic ulcer disease exacerbation or recurrence, and maintain their pain at a tolerable level. We want them to monitor their stools. We're going to monitor their stools and their gastric drainage for blood, IV therapy. Okay, sorry. Anyway, back to restoring and maintaining fluid balance. They might have an NG tube. We need to make sure that it's patent in the right place and monitor their hemoglobin and hematocrit, of course, to make sure there's no blood loss that we're not aware of. And electrolytes, BUN and creat values. Check their abdomen every 4 hours, maintain bed rest, and keep the head of the bed elevated, of course. We want to manage their pain and administer their medications. They're probably going to be on PPIs and some other medications. Relaxation and stress techniques, stress reduction techniques, lifestyle management, and we want to make sure that we take care of any pain that they might have, but that we evaluate it and make sure that it's not just from the ulcer. It could be from a complication or could be unrelated. Okay, so rest is important. Nighttime ulcer pain happens between 1 and 3 a.m. So it's really important for them to take their medicines as prescribed and limit food after their evening meal and to use relaxation and techniques and comfort measures. We want to promote balanced nutrition. They might reduce their food intake because of the pain, so we want to make sure that they're getting the nutrition that they need. Check out their diet, see what kind of eating schedule, food that they're eating, and see if they can associate any of those foods with pain or if they're avoiding certain foods because of pain. If they need to, we can refer them to a dietitian for meal planning. Also, we want to look for anorexia, nausea, vomiting, those kinds of things. Well, the evaluation is the same as always. Obviously, we want to make sure there's no complications. We don't want to see any bleeding, uncontrolled or excessive bleeding. Make sure they have a balanced diet. Excuse me. No signs and symptoms of fluid overload or dehydration, and that their pain is tolerable. They get rest and have reduced occurrences of peptic ulcer disease. So again, we want to see a decrease in symptoms, and we want them to be able to do their normal activities. If they don't progress satisfactorily, we need to do a thorough nursing assessment again, notify the primary care provider if there's any signs or symptoms of bleeding. There might need to be a further workup, and surgical or endoscopic consult may be needed. Haha, we have made it to the end again of another session. On your PowerPoint, actually not on your PowerPoint, but the PowerPoint, the questions PowerPoint, there are a lot of questions related to peptic ulcer disease, so I think it would be a good idea to work those questions through, make sure that you read the rationales And hopefully this will answer any questions that you have, and I will get this posted so that you have access to all the videos. And I hope you have a great day, and hopefully I will see you tomorrow morning. But if not, check out those videos, and have a great night.